All right, good afternoon, everyone, and welcome to the webinar today. My name is Adam, and I'll be your moderator. Our speaker is Dr. Heidi Kohltfarber, and she'll be talking about unexpected findings from CBCT scans and what to do with them. Today's webinar is also sponsored by Dentsply Sirona. All right, Dr. Kohltfarber, welcome back.
Thank you. Today, we're talking about some unexpected findings that we might see in our CBCTs and what to do about them. And I think it's really fun because, of course, there's common things we're going to see in our CBCTs, and we might be interested in understanding a little bit better what we should do with those. But there are those times that we see some very strange things. And so I've put a lot of fun cases in here, some things that we've seen recently, and hopefully you will have a lot of fun with it. So thank you for spending your evening with me. And I think we're going to have a pretty fun time. All right, my little disclaimer, I have received financial contribution from Henry Schein for this webinar. I am a key opinion leader for Dentsply Sirona, Henry Schein, and other imaging companies on faculty at CDOCS. And I am a founder and managing radiologist for Dental Radiology Diagnostics, which is my private practice, all designated to radiology, and I have no commercial bias. All right, so our objectives for this is we're going to just talk a little bit about some of our incidental findings, what to do about them, how to describe them, how to send these cases on, and things we might want to talk about with our patients. And it kind of helps us to have just a little bit background of our incidental findings. And so there has been research conducted looking at some of our strange incidental findings. And by and large, we look at, I would say various classifications as far as what we're looking at. And so this was one of the earlier studies that came out by Price et al. In 2012. And it went ahead and looked at an older population. So this was looking at a population with an average age of about 49. And in that particular population, they found that the majority of issues were within the airway space or soft tissue calcifications. And then, of course, it goes all the way down to pathology being just, 0.1%. So very, very minimum amount of pathology at this time. One of the nice things that it did do, though, is it looked at those incidental findings and it said, well, what should I do with these? How much of these are actionable? And it found that about 30% of the cases are going to be actionable. And that was divided between active monitoring and something that was interventional or referral. So we can expect that, about 30% of what we find, we actually need to do something with. The rest are truly just incidental findings we don't need to worry about. Next, Edwards came along in 2014, and he was looking at an orthodontic population. So the average age of these patients is 14. So we're looking at our, pediatrics. And in our pediatric population, the largest degree of incidental findings were found within the naso-oropharyngeal region, which is what we would expect, especially if we are interested in airway space, is exactly what we would expect, because you're looking at, enlarged tonsils. You might be looking at, some deviated nasal septums, that sort of thing, things that would impinge the airway space. Paranasal sinuses, of course, you've got kids. We do see a ton of stuff in the sinuses, and I will show some of that today. But of course, children, we're going to tend to see kids that are a little bit more snot-nosed, so they're going to have some mucosal thickening within the sinuses. And then that went all the way down to our cervical vertebra. So we do see various congenital anomalies within the cervical vertebra region, but this tended to be the majority of what we saw within that particular group. And next we come to Lopez et al. In 2017. When they were looking at it, I think their average age was a 37-year-old, but their entire cohort was anywhere between the ages of 8 to 91. And what's interesting with these particular cases is they were all imaged for implant treatment planning. So you've taken your CBCT, you're looking at it for implants. What other things might you find? And so in this particular group, the number one thing that they found was something within the dental alveolar region, followed by airway and soft tissue calcifications, and then TMJ bone and lesions of the jaws. So lesions of the jaw were about 2%. And then they had an other, which was about 2%. So that might make up some of our congenital anomalies and that sort of things. What I have found is the older the population, obviously the more soft tissue calcifications you're going to have. So if you have imaged Mrs. Jones and she's 82 years old, you're going to see a lot of soft tissue calcifications. So that will be a huge amount of your incidental findings for those cases. The other thing with Lopez et al. Is they found that the majority of cone-beam CTs will have incidental findings, which we already know. Average amount of findings is about 3 to 4 incidental findings per CBCT. So these are findings you completely were not expecting to find. You open it up, you have, you're just going to plan your implant or whatever it is, and you have found 4 additional findings, 3 to 4 additional findings. In this particular one, it found that more of them were actionable. So it found that about a 60% were somehow actionable, needing treatment, about 30%, and the other 30% needed some sort of monitoring, which means you might have that patient come back and re-image them at a certain point to look for, say, a growth potential in whatever that particular entity was. When we look at all of the studies to date, we see on average, we can say 3 incidental findings per scan. That's what you can reasonably expect to find. I would say overall 30% probably actionable. That's probably a really good number there. Again, there's a huge variety as far as what's out there. And our treatment might have other diagnostic tests, vitality testing, periodontal probing, those sorts of things, or active monitoring, as I said, bringing that patient back to re-image them, or a referral out for some other reason. And I want to talk a little bit about referrals, because what we see radiologically, and because of the world that we live in radiology, we do tend to send things in the sinuses, any of the paranasal sinuses, that sort of thing. We tend to think of ENT. And so you'll notice that I'll say ENT. Sometimes people ask, well, what about oral surgery? And certainly, if we find stuff within the maxilla or the mandible, absolutely that is going to oral surgery. When we get into our sinuses and our airway space, I understand there's a little bit more of a turf war between some of our oral surgeons and ENT. And so for that particular reason, I really have to say, whoever is good in your area, that is who you're going to want to send to. Some area, oral surgery is just absolutely fantastic. They're hospital-based. They know exactly what it is they're doing. Many of them might have taken, a plastics residency as well. So I think in that regard, definitely that would be who you want to send to. But there's other areas where that might not be the case. And you might have, an oral surgery group that really just takes out third molars, and maybe they're not, taking out, your tonsils, your adenoids, that sort of thing. And so it really depends on the area that you're at. And so I'm just going to put that caveat out there. All right. Okay, so we wanted to break it down by some of our anatomical regions. And because there are so many things that we tend to see, I'm going to go pretty fast through some of these. Some of these may not necessarily affect you. So definitely dental alveolar, maxillomandible, temporomandibular joints, paranasal sinuses, airway. For today, we're going to go ahead and skip the temporal bone. We do see a lot of things there, but I'm going to skip that for today because I really want to show you some cool cases and stuff that we've seen within the skull and skull base, orbits, soft tissues. I've got to hit the soft tissues today because you will see so many things within the soft tissues, and definitely the cervical spine, because when you open up, especially your large volumes, that's the first thing you're going to see in your MPR view is going to be your cervical spine. So I want to talk about that as well today. So, all right, let's start with our dental alveolar. Certainly our periapical lesions, number one. I'm sure you have found a lot of incidental findings within the periapical region. I think that CBCT is just in a fantastic place to help us to better understand what's going on with our patients and to help educate our patients. So it is very common to see periapical lesions that we didn't know that the patient had, or the patient didn't realize that they had. And the reason being is because unless those buccal and lingual cortical borders are breached, we can't see that lesion on 2D. So you may not have seen it before, but now we look with our CBCTs, we're looking between those cortical borders and we can easily see that periapical lesion. So I have to include this because this obviously is our number one. Now you'll also notice with this one is we have nice mucosal thickening within the sinus. It is odontogenic in origin. We have erosion of that inferior cortical border of the sinus. We can see that very nicely. And this is all our odontogenic inflammation. So we would want to look at that before attempting to send that off to ENT. Definitely want to make sure that we rule out an odontogenic source if the patient has a mucosal thickening. So always important to remember that. But obviously this patient needs root canal treatment or extraction. And as dentists, we are really good at figuring out what to do with that. When we send these things back, of course, we'll say vitality testing to corroborate the radiographic findings, because legally that's what we have to say. But of course, looking at that, that is a ginormous lesion. We need to do something about that. This is another one where we have a large lesion going on. And again, we have a little bit of a mucosal thickening within the sinus. It looks like we do have thinning and erosion of the cortical border. So I would say that mucosal thickening is odontogenic in origin. So what the other thing that we would look at with something like this is we wanted to view if there is any sort of a root fracture. Sometimes we can see it and sometimes we cannot. That fracture has to be displaced more than the resolution of the image. So if you took it at 0.2 millimeters, the fracture has to be displaced more than that for us to be able to see it. The other thing that we might look for are small step defects. Sometimes we can't see the actual fracture line, but we can kind of see an irregularity along the border of our root that might tell us, yeah, something's going on that does not look normal. We also want to look for things like asymmetric widenings of the periodontal ligament spaces. So those are the types of things that we would look at if we're considering a root fracture for that case. Now, of course, we can see various anomalies like our dens and dentate. It's very, very easy, of course, with our CBCTs. I'm sure you've probably already all seen them, but you can see this kind of keyhole shape that we've got within the coronal aspect of our tooth. Usually we see them within the lateral incisors, and we can see that hyperdensity that is around that little hypodensity, and that looks isodense, which means it's same density to our enamel. So it's isodense to enamel. And obviously that's going to need to have root canal treatment. Many times we do have our apical lesions. Certainly we do with this case. And if we see it on one side, we want to check the other, make sure that it's not bilateral, because it can be. External root resorption, absolutely we can see that. We can see external versus internal root resorption very nicely. This one looks like somebody took a bite out of that tooth, and we can see a nice draining fistulous tract as well. We can use this technology to show Mrs. Jones what's going on, because external root resorption can be very difficult for the patient to understand. Try and tell her there's a hole in your tooth, and she's saying, but I don't feel anything. I think that we can definitely use this as far as education, show Mrs. Jones exactly what's going on. And it can also help us to determine whether this tooth is something that we can save or not. Obviously, these teeth have a poor prognosis. Internal root resorption, we're looking for this internal granular hypodensity. So you can see that internal granular appearance, and we have enlargement of the pulpal chamber and canal. This is another case. We caught this really, really early on. This patient had some pain and sensitivity. We could see a slight widening of the periodontal ligament space. You can see that there in the image. And we can use symmetry. So if we were comparing one side to another, you could see that, yeah, this distal buccal canal is slightly enlarged compared to the other side. Now that could be a variation of normal. Yes, very true. But when we're looking at it, we do see this fusiform enlargement within the canal, and it is very small at this point. We definitely do have some apical pathology, and if we catch it at this point, that patient might have a good prognosis with that particular tooth. Radicular cysts and versus granuloma, of course, we do see radicular cysts. One of the things that can be confusing when we are looking at our sinus is that we're trying to decide whether this particular lesion is odontogenic in origin or if it's something that's coming from the sinus. And sometimes that can be very difficult. You notice in our axial section, it almost looks like a ring within a ring. So we know instantly we're coming down through, okay, we've got a cystic process going on here. We've got a corticated border inside of our sinus. And when we're looking at our sagittal sections, you can actually see that superior displacement of the inferior cortical border of the sinus. That lets us know that, yes, this is odontogenic in origin. This is originating from the alveolar bone. In which case, of course, we're going to want to look at the first molar, go ahead and do vitality testing, but it looks like the epicenter is probably our non-healing root canal treated tooth. So probably thinking about retreatment versus extraction. Right, our unfilled canals, we do regularly see these, and sometimes the patient is not exactly sure what's going on. Sometimes the patients have symptoms and other times they do not. And so I think this is one of those things that we always need to broach very professionally. We don't know what happened when that original root canal treatment was performed. And so I think from that standpoint, it always behooves us to be very kind to whoever was their previous clinician and just state the facts. And that's something with radiology, is we just state the facts. And I would say that's a really good rule to live by. Mrs. Jones, you have an unfilled canal. For whatever reason, this canal was never properly cleaned, and you have pulpal tissue in there. And then, of course, we'd want to do a retreatment with that particular tooth. Now, in this case, we do see that we have an apical hypodensity. Many of our root canal treated teeth will have an apical hypodensity, and we have to decide, is this non-healing or is it healing? Well, in this case, we can clearly see that, yes, we have pulpal tissue that was not properly cleaned out. Most likely this is non-healing root canal treated tooth. But sometimes we see this exact image and everything's been done perfectly. We have no unfilled canals, we have no fracture lines, and the patient's not in any pain. In which case, we're going to say this is most likely a fibrous healing defect, because we do see fibrous healing defects very commonly at the apices of teeth. So just kind of keep that in the back of your mind. If you see a hypodensity at the apex of a root canal treated tooth, it does not necessarily mean that it is non-healing and actually needs treatment. We have to look at that. We have to look and see if we're missing a canal, if we have a fracture line, and then we have to take the patient's symptoms into account as well. So what we see radiologically is just a part of the puzzle, but not all of the puzzle. Root fractures, yes, we do see these as incidental findings. This patient had no symptoms. This patient had no symptoms at all. Didn't even know they'd fractured it. So that's kind of interesting. And then we want to assess, where are we at with that tooth? Do we have a large apical lesion? Perhaps this is old trauma and has healed. Maybe we don't need to do anything, but obviously most of the time we're going to need to go ahead and go in and extract that tooth. Now this is a root canal treated tooth. We do have a lot of beam hardening artifacts, so you can't always see the fracture line. Again, it must be displaced more than the resolution of your machine. But we also want to make sure that we're not just looking at a beam hardening artifact. So your beam hardening artifacts can line up, well, typically will line up with your filled canals. So if it runs right along next to your filled canals, you might say, maybe it's beam hardening artifact. We're going to have to look for some other evidence, such as bone loss, to let us know that we have a root fracture. But in this particular case, you can see that this vertical fracture does not follow the canal. And of course, we do have a patient with symptoms, and we had no buccal bone in this area. So all of the evidence added up and lets us know, yes, we definitely have a root fracture that we can see. So, all right, supernumerary teeth, we see these all the time. We can see them all over the place. Sometimes they're swimming upstream. It's like this little guy right here. Many times they have some sort of resorptive process. Any long-standing impacted teeth will have a resorptive process. Concrescence, fusion of the cementum. And what we can notice here is that that periodontal ligament space actually goes around both of the teeth. So definitely want to know this before you decide to extract the teeth. We did have an interesting example of this when I was a general dentist in private practice. One of the partners was trying to do serial extractions on a 12-year-old, and he's working on it. He's working. I can't get this tooth out, and then all of a sudden, two popped out. So it was like two for the price of one day. But in reality, there was concrescence, and had that been visualized beforehand, obviously alternative treatments would have been thought about. But with CBCT, it's very easy to be able to see that we have concrescence. So anastoses, I do want to mention these because we see this is dime a dozen. We see tons and tons of anastoses. Now, these come as different names. You might have learned it as idiopathic osteosclerosis or dense bone island. It's basically all it is. It's continuous with the cortical borders. There is no expansion or thinning of cortical borders. It is the same density as isodense to the cortical borders. And the teeth, you want to look and make sure you have the periodontal ligament spaces around those teeth, that it's not attached to the teeth. Obviously, it's not doing anything to our mandibular canal. And so this is just our anastosis. These are do not treat lesions. We don't need to do anything about these. Now, rarely, they can cause a little bit of apical root resorption. And again, we want to look and make sure it's not actually attached to that tooth. You want to be able to see that periodontal ligament space around the tooth. And of course, we want to make sure that is continuous with our cortical borders. So again, if you have any questions, always send them. You can send them out to maxillofacial radiologists. Like I said, we see these a lot. And but they do not touch lesions. We don't actually need to do anything about them. And actually, you can find them anywhere throughout the skeletal bones. So they're not just unique to the oral cavity. In fact, many of the things that we see are not just unique to the oral cavity. You really see them throughout the whole body. And I think that's one of the beauties of radiology, is it really puts that whole patient care together. Enlarged marrow spaces, we commonly see these, and we commonly get questions about these. One of the areas that we're going to see an enlarged marrow space, also known as our focal osteoporotic bone marrow defect, is right at the anterior midline. So we can see it right here. It's a very common area for us to see them, but we can see them anywhere. Again, if you have any questions, if you're concerned about what this might be, you can send it out to a radiologist. The things that we're looking at cortical borders. Make sure that those are nice and intact. Looking at the effect that it might have on the surrounding structures. Obviously, an enlarged marrow space is not going to really have any effect on the surrounding structures. And with that, I wanted to show you a really fun case that we got last week. And we're looking at anterior mandible. I know this is turned a little bit cockeyed here, but this is our anterior mandible. And this particular patient was completely asymptomatic, nothing going on. This was completely incidental finding. And it looks like we have something. Definitely a hypodensity. Look at the border to it. The border to it is kind of atypical. It's kind of a thickened and sclerotic border. So definitely a very different border. And because we know we're in the anterior mandible, and it was a very, very small volume that was sent, you can see that we might have a similar appearance elsewhere within the mandible. So that's another thing. You can look at your trabecular pattern. Is this normal for that trabecular pattern, or is there actually something going on? With this, you'll notice again, your cortical borders are nice, smooth, and intact. No thinning, no expansion, no effect on any of the surrounding structures. And so we said, okay, this could be our osteoporotic bone marrow defect. I think this was a 30-plus-year-old female. But one of the things that we can see, and this is fairly rare, which is why we added it, but we do think it's fairly rare, is you can have a patient with a history of a simple bone cyst that will spontaneously heal. And in doing so, you'll also get this kind of a ring-like pattern as that bone starts to fill in the defect. And so that is something else that we might consider. But with this, we definitely want to reevaluate this patient. So obviously right now there's no expansion, there's no thinning cortical borders, there's no symptoms at all. We're going to say, this is an area that we do see osteoporotic bone marrow defects, but we can't rule out a simple bone cyst, which is also known as an idiopathic bone cavity, just so you know, because you might see that later on in the volume or in our lecture today. So it could be a simple bone cyst that's in the process of spontaneously healing, but we want to see a reevaluation of that patient in 3 to 6 months. What you're looking for is a growth potential. If this has changed in size, it lets us know there's something more going on and that patient might need a biopsy. If it has not changed at all, or if more bone has filled in, then we know, all right, we probably do have, maybe just an osteoporotic bone marrow defect, or it could be something that's in the process of healing, and we're just going to kind of monitor that and watch that progress happening. But again, when in doubt, you can always send it out. Osteoporotic changes, we do typically see these. I know you've probably seen them a lot. We see this generalized thinning and pitting of the cortical borders, and you'll notice that you have a real granular hypodense appearance within the trabecular pattern. You might notice it because you start to lose that nice crisp cortical borders around your mandibular canal. You're not able to see the mandibular canal. So if you're placing an implant, that's going to make things pretty difficult. So this is a great case for osteoporotic changes. We can see various iatrogenic problems. This is not uncommon because now we're able to, in 3D, check everybody's work, including our own. And again, I would say just state the facts with what we see, because we don't know the particulars behind how something like this might have happened. So I would, obviously, ethically speaking, we need to alert the patient to it. But I would be, just stating the facts. This is what I'm seeing on the x-ray, and this is what we might need to do with that particular tooth. I can't imagine that this doesn't hurt that patient, because that pin is extending all the way down into the bone. All right, benign fibro-osseous entities, we see these very, very commonly. I think in school we learned that typically these were middle-aged females, but that's not always the case. So this particular case actually is an elderly male. And so really we're looking at our symptoms, our appearance. Obviously we have a mixed density entity. We can see that it's kind of associated with the apices of the teeth, thinning and expansion of the otherwise intact cortical borders. This is what we want to see to call it a benign fibro-osseous entity. Or it might have a ground glass appearance to it. Here we can see some nice little mixed density entities at the apices of these teeth. This one's been root canal treated, because when they are immature early on, they will look completely hypodense, and someone will think, oh, we've got a periapical lesion. So we always want to make sure that we do vitality testing on those teeth, especially if there's really not anything going on that particular tooth. If it doesn't have any large restoration or anything like that, that should be a red flag to us, and we should always do vitality testing. These teeth will be vital, even though we have these nice little mixed density entities. So that's kind of our clue. Teeth are vital. Again, radiolucent or hypodense in that immature stage. These patients are at increased risk for infection because we have a poor vascular supply in this area. So we can monitor these, but we really don't need to do anything about these. And here's some other cases of some great benign fibro-osseous entities. If we have them in 2 or more quadrants, we're going to call it florid osseous dysplasia. This actually will increase the patient's risk for osteomyelitis. The teeth are vital. And again, we have this thinning and expansion of otherwise intact cortical borders, and we have this nice ground glass appearance or density to the bone. So this is classic for a very immature or early on florid osseous dysplasia, so that expansion and thinning of cortical borders. So it's something where if we see multiple of these, we have to think this is one particular entity. We have had cases come in where the patient has had half of the jaw removed because they had a history of a large cyst. And now you can see in the remaining half that they have fibro-osseous dysplasia. Again, radiology, we just state the facts. We're going to leave it as that. But you always kind of wonder in the back of your head exactly what happened with that, if perhaps that would have been a misdiagnosed entity. And you sure hope that's not the case. But in radiology, again, we just state the facts as they are and move along. It's not for us to sit and try to guess what happened. This particular case came in, a patient has this non-healing root canal treated tooth. They're not entirely sure what is happening. They think, maybe it's just our apical lesion. But what we're looking at is we're seeing some nice scalloping of this particular entity in the anterior mandible. We had very, very minimal expansion with it. And with this one, we start to think about other things. We start to think, well, anterior mandible, it's something that's scalloping nicely between the roots of the teeth. This was an older individual. Younger individual, we would probably say, oh yeah, that's got to be a simple bone cyst or idiopathic bone cavity. But we also would consider an odontogenic keratocyst. And in an older individual, that might be the number one that we think about is an odontogenic keratocyst. These tend to have very minimal expansion, and they have these nicely scalloped borders. Obviously, this patient had a history, I think, of treatment and retreatment. And so they were trying to decide if they should just extract the tooth at this point. And what we would say is don't extract it. It's most likely we've got a pathology. Go ahead and do a biopsy and see what it is. So I believe this was an odontogenic keratocyst. All right. Let's talk a little bit about the maxilla as well. Nasopalatine duct cyst, that's a fairly common one for us to see. We'll see an enlarged incisive canal. We want to measure that. If it's larger than 6 millimeters in diameter, we're going to say, well, it could be a cystic process or it could be a variation of normal. In which case, we want to look in our sagittal sections. And this is what I would like to see to call that an incisive canal cyst or nasopalatine duct cyst. But sometimes this is what we see up here, and you'll notice we're just missing a bunch of our palatal bone. Well, I'd want to look at that clinically. These nasopalatine duct cysts, sometimes you're going to see a soft tissue protrusion. It might look a little bit purple, that sort of thing. If you don't see anything at all, this might be a case where you say, you know what, nasopalatine duct cysts are so slow growing, Mrs. Jones. I might be concerned that something's going on, but let's go ahead and reevaluate this within 1 to 2 years. Because these are very, very slow growing, that would give you enough time to see what would be going on with that. So this is one that we might monitor. This one right here, we're going to go ahead and take out. This is one we might monitor. All right, cheek augmentation. Our patients many times like to have various things done. And so it is not unusual for us to see some sort of augmentation. And many times patients don't tell us they have this because they don't want anyone to know. We were told by plastic surgery, please don't tell the patient that their cheek augmentation material is asymmetrical, because obviously that's the whole reason they went in to have it done, is because they felt like they were asymmetrical, or they'd like to be plumped up nicely. But yeah, plastic surgery said, please don't tell them that this is not symmetrical, because then they come running back to their office all freaked out when, clinically they look just fine. It's just radiologically, it might look asymmetrical. What we tend to see is this kind of clumping, hyperdense pattern. Sometimes we see stranding, so we've got some stranding here. So stranding and clumping along the cheek region lets us know that we have a history of a dermal filler. And again, don't mention asymmetry. This was an interesting case. This patient came in and we see these metallic hyperdensities everywhere. In fact, if you look at it on our 3D volume, you can see it's all over the place, and it follows the vascular supply. So this was a particular case in which the patient had gone in the morning to have a CT with contrast. The contrast had not completely washed out of the small vessels of the facial region. And when imaging was done to look for bone levels for implant treatment planning, this is what they found on their CBCT. So this was a really fun case. Of course, this patient came to us with no history whatsoever, but it was classically following all of the vessels. And obviously it's metallic in appearance, which is what we see with our contrast materials. So we would say, go back and review that patient's history. Ask them if they just had a CT with contrast. But I think the vascular anatomy is just so beautifully represented that this was a really, really fun anatomy case. So sometimes it really makes our day. We do see a lot of neurovascular canals that we don't typically see with our 2D imaging. Don't be surprised by that. Our vascular canals look very linear in appearance with nicely intact corticated borders. So of course, we can see our anterior superior neurovascular canal tends to come down around the canine lateral region. This one may not have read our textbook because here it is, during right around the incisal region, not really our canine region, but that's okay. There is some variation, and we can see the size of that. So if you're thinking about placing implants, you would want to avoid that neurovascular canal because that bundle is quite large. It's going to cause a lot of bleeding if we were to get into that, and it could cause neurosensory deficits due to the size of that particular canal. We can also see the posterior superior alveolar neurovascular canal, and this goes along the lateral inferior aspect of the sinuses. And so we'll see it extending all the way along that lateral inferior aspect very nicely. Now, if you're going to do a sinus lift and bone graft, that's something you want to look for because, again, we don't want to encroach on this particular little canal. The main reason in this area is it's going to cause a lot of bleeding. It's going to be very difficult for you to see your surgical site. Rarely, it can also cause a disruption in sensory deficits or cause a sensory deficit. So definitely something that you want to look at when you're doing any sort of sinus augmentation procedure. This was an interesting case. This was a 60-year-old female. This came in from the endodontist, and the question was, which tooth do we root canal treat? This is tooth number 7. This is number 8. Number 9 was avulsed years ago, and this is number 10. And what we could see with our CBCT is we actually have this large defect. So that's what's actually getting imaged in that 2D film, is we're seeing this particular defect and it's being projected across into our 2D film. But when we look at it in all 3 planes, we see, no, we have an undiagnosed cleft palate. You can see that very, very plainly from our images. And this was a fun case because we let the endodontist know exactly what was going on. He came back and he said, I talked to Mrs. Jones and she says she doesn't have it. Well, doesn't have what? She doesn't have a cleft palate. And again, that's why I just love radiology because it is the facts, ma'am. So I've never seen anyone want to have root canal treatment, but she evidently did. She'd rather have that than a cleft palate. So I thought that was pretty funny. All right, let's talk real quickly about our mandible. We can have salivary gland depressions. It's called a Staphny bone defect. I know you learned about it in dental school. We tend to think about it as being in the submandibular gland region, but it can be anywhere that you have glandular tissue. And so here we have our sublingual salivary gland in the anterior mandibular region, and we have this nice lobulated appearance. What you'll notice is that we have intact cortical borders. So that's very important. Lets us know that we have a slow growing peripheral entity that's pushing in on that bone. So the body has time to react to that and to kind of wall that off with that remodeling of our cortical border. These are not epithelial lined. They can look cystic. Obviously, this was of great concern, but their CTs will show fatty and glandular tissues. It is idiopathic. We don't know exactly what causes this. There's a host of different theories, but in the end, reality, we really don't know exactly what causes this. no treatment is needed. So seeing this nice, thick, intact cortical border, or seeing our thick cortical borders, is fairly pathognomonic for this. And of course, the location. Location, location, location. This is the typical one that we're used to seeing, the submandibular salivary gland depression. This is below the mandibular canal. So if it's below the mandibular canal, it is most likely not odontogenic in origin. And again, it's thickly corticated. And when we look at it in all of our different planes, we see that the cortical border is otherwise intact. It lets us know that there is that peripheral slow-growing entity occurring. So kind of some important things to look at, but classic location is submandibular salivary gland. Now, this one was really fun. I have to put this in here because it was so cool. It's like seeing a double rainbow. It's nice and rare. In fact, it's probably rarer than a double rainbow. This was a double Staffy bone defect. So we can see 1 and 2. 1 and 2. So that is just a really fun case. Again, no treatment is needed for these. We can also see it in the parotid gland region. The tail of the parotid wraps around, and we can see it right at the lingual aspect of the condylar head. Again, thickly corticated. Otherwise, everything is intact. We know based on the location, and we don't really need to do anything about this. There has been some concern about weakening of the condylar neck. We have never seen a case where we had a condylar neck fracture as a result of just the parotid salivary gland depression. Would it be easier to fracture if they were in some sort of a car accident or something like that? Maybe. But by itself, it's not going to cause that. Fibro-osseous entities at the angle of the mandible. This is not a location we typically think about, but is one that we typically find. And so the things that alert us, obviously, it looks like we have a mixed density entity in the region of the ascending ramus. We can see some expansion and thinning of the otherwise intact cortical borders. Again, we have that kind of ground glass appearance to the internal aspect. It's below the mandibular canal. Lets us know this is a fibro-osseous entity at the angle of the mandible. If you are ever concerned about what this might be, which obviously these cases were sent to us for that exact reason, we would say reevaluate it in 3 to 6 months. We want to make sure that we rule out a growth potential. And so I would reevaluate that in 3 to 6 months. If it's really not changed in any size at all, then I would go ahead and say, yes, we do have our benign fibro-osseous entity or focal osseous dysplasia, and we don't really need to do anything about it. We might want to kind of check up on it from time to time. And certainly if the patient had any symptoms, we would want to get that looked at immediately. Now, various canal variations, we can see that. I'm sure you're used to seeing that. We have superior accessory canals. We can have bifurcations and trifurcations of the canal. So obviously reasons that we'd want to trace that canal or map that canal. Here's our chin augmentation. So we can typically see this hypodense appearance. It's buccal to the mandible. And sometimes you see this bone, actually most of the times you see this bone growing out and around it. And it's because these bone grafts are very porous in nature. They're built that way so that the bone does grow in and around and through them and anchor that implant to the bone. So that's actually what they want it to do. This was a great one. You can see that beautiful grid pattern as that bone has gone into all the porous little areas. So it's doing exactly what it's supposed to be doing. But sometimes our patients don't really tell us exactly what is occurring. So this was a great case. This one came in, 72-year-old female, presented with pain and swelling in the lower left area. Our clue when we come in, of course, is that this is bilateral and crossing the midline. So we're thinking, okay, already we've got some stranding. We've got that hyperdense stranding appearance. So we're already starting to think, this looks kind of like augmentation of some sort. We can see the classic pattern. Many times you're going to see almost like a little divot in the bone from where that particular augmentation material or graft has been sitting. Because they are porous, it can kind of wear down the bone, and sometimes they'll actually make a little bit of a trough for it when they're putting that in place. But this was an interesting one because she actually did have some pain and swelling. On palpation, it was actually very crunchy. So there was definitely these bony spicules that kind of made a crunching sound. So lovely, isn't that? So that's how it was sent to us. We didn't have any of this history at all. And so when we called in and talked to the clinician, and we said, really majority of the area, the cortical bone is intact, but we are starting to see a little bit of erosive changes here near our number 22 region. But the majority of this looks like pretty standard cheek or chin augmentation. So that's kind of where we were thinking is something happened. Somehow we have an infection going on in here. That can happen. But thinking about the age of the patient as well. So when we talked to them, they said, well, she had a history of chin surgery as a teenager. So she had augmentation procedure as a teenager. She's now 72. We're talking, 50, 60 years ago. What did that augmentation material look like? And we could have some silicone back then that had kind of an oil-based silicone. Now, the patients, again, they don't like to be very forthcoming in telling us these interesting facts. They did go back and talk to her again, and she said, oh, yeah, about a year or two ago, I had another little procedure. And in that one, she had some chin fat reduction, and these nylon strips were placed. And so, she probably had no issue with the original augmentation material. Obviously, she's had it for 50, 60 years and had no issue, but this is something that is new. And so for us, we would start to think, okay, she probably had, had some sort of procedure, and then we have a secondary infection. So we have introduced some sort of a secondary infection into the area, which can happen with that. In that particular case, we did recommend an MRI because we want to be able to evaluate what is truly inflammation in the area. And rarely they need to go in and actually debride these areas, which can be very, very difficult in a patient that's had multiple chin augmentation procedures. But unfortunately, it sounds like when they went back in that something got nicked, something happened. We might even have some of that oil-based material leaking out and causing some of this calcification. So kind of an interesting case. All right. We can have variations in our canals. This is our lingual canal variation. We can have our lingual submental canals. You're going to see a lot of neurovascular canals. These are completely normal. Again, linear hypodensity with nicely corticated border. Odontoma, so we can see pathologies. Of course, this looks like multiple of these little teeth within one cystic space. Obviously, this premolar never erupted. At this patient, she's an 82-year-old female. We're not going to do anything about this at this stage, but a younger individual will go ahead and remove these. But many times, of course, the imaging is done because the tooth has not erupted, and you'll see this kind of mixed density appearance with what looks like multiple little teeth. I tend to think of it as like a compound odontoma. It's compounded into little teeth, but you can also get complex ones as well. All right, temporomandibular joints. I'm going to go through this one really quickly just because of time, and I want to show you some of the other things. And we did do a really fun lecture not too long ago all about the temporomandibular joints. So I would definitely urge you to go back and look at that. But basically, we use the research diagnostic criteria for TMD to evaluate the osseous structures. And in that, it takes 11 different criteria and it funnels it down to no osteoarthritic changes, or maybe it's indeterminate for osteoarthritic changes, such as adaptive remodeling. We see that with articular surface flattening alone, with nothing else going on. You might say, well, we have some adaptive remodeling. Or yes, we have osteoarthritic changes. And with yes, osteoarthritic changes, we're going to see subcortical pseudocysts, surface erosions, anterior osteophytes, or a generalized bony sclerosis. And again, this is normal, nice intact cortical borders. This is also normal. This is a bifid condyle. I mean, these are so cute. You just want to send this lovely image to your loved one and let them know, hey, I love you with a beautiful heart. But yeah, we have otherwise intact cortical borders. So there's my nice little nerdy radiology person. Flattening of the superior lateral pole. Again, this might be the first thing we see, but you have otherwise intact cortical borders. Then we start to see little surface erosions, anterior osteophytes, generalized sclerosis. This has generalized sclerosis, anterior osteophyte, thickening of the glenoid fossa region. So any thickening and sclerosis of cortical borders tells us that we have some sort of an inflammatory process. We have a nice subchondral pseudocyst. We have some more little subchondral pseudocysts. These are also known as geodes or Eli cysts. But commonly we will see these within the temporomandibular joint region. Okay. This was a case that was sent to a 62-year-old female. As it was presented to us many times in radiology, we do not get any information. So if you're sending a case out to your radiologist, please add some information. It's very helpful. So obviously we can see we have these multiple punched out lesions all throughout the temporomandibular joint. This does not look like normal joint disease. And so with that, of course, we're going to call the clinician and say, hey, this patient doesn't happen to have multiple myeloma, does she? And it came back, oh yeah, we forgot to tell you. She has late stage multiple myeloma. So yes, we can see this. Again, that punched out lesion, kind of a spotty bony sclerosis. Spotty bony sclerosis tends to let us know, yeah, we probably have some type of malignancy going on. But those beautiful punched out lesions are perfect for late stage multiple myeloma. Okay. This particular case came in, and this came in right before Christmas, so it was a pretty rough case. This patient did have osteonecrosis of the jaws. He has a 66-year-old male with a history of stage 4 lung cancer, thought to be in remission. For 2 years, he's really been battling with temporomandibular joint disorders. He can't figure out what is going on, and he thinks that it's just TMJD. He's been to multiple clinicians trying to figure out what is happening. And what you'll notice when you're looking at this is we have this kind of a ivorine white appearance to it, very extensive bony sclerosis. We also have these massive erosive changes, kind of this moth-eaten pattern at the ascending ramus that lets us know this is looking very metastatic to us. And in fact, we felt like this looked a lot more like metastatic lung cancer. So some of our cancers, we think of metastatic disease, we think of moth-eaten and hypodense, not necessarily the case. Occasionally, they can also be hyperdense as well. So with this, we would send them off for a PET CT. This patient really needs a team approach between medicine and dentistry. Patient does also, like as I said, have osteonecrosis of the jaws as well. And so this needs to be treated with a team approach, but definitely patient needs to go back for a PET CT because it looks like we've got some pretty aggressive metastatic lung cancer. And unfortunately, this patient was completely unaware of this. So really bad timing to be able to tell him right before Christmas. All right, paranasal sinuses, I'm going to go through really, really quickly because we don't have much time and I have fun cases I want to show you. The majority of us will see things within the sinuses. Of course, we're worried about the sinus drainage pathway. We did do a whole lecture recently on paranasal sinuses, so I would definitely encourage you to go and spend some time with that if you are interested. We commonly see these little polyps within the sinus, and we're looking for our nice intact cortical borders to make sure that they are okay. Most of these just have to do with allergic sinusitis. When we get into, say, our acute rhinosinusitis, these patients have kind of a bubbly appearance. This lets us know we have active secretions, and we have otherwise smooth and intact cortical borders, letting us know this is an acute or allergic rhinosinusitis. We want to rule out the teeth with any of these things, but we don't really need to do anything about this. Chronic sinusitis, again, with any sort of inflammation, the body starts to lay down additional bone. We can definitely see that here, that thickening and sclerosis of cortical borders. We have some dystrophic calcifications floating within the sinus, but this could also be a sign of fungal infection. So we would want to send this to ENT to go be looked at. We do have an enlarged osteomeatal complex. So lets us know we have a history of previous sinus surgery, but we do want to send this patient back to rule out a fungal infection. We can see hypoplastic sinuses. 2% of the population will have this tiny little sinus on this side, super cute. Many times we have mucosal thickening because our drainage pathway is not fully developed. So it's very common. And again, you're going to see that obvious asymmetry in that particular regard. Pneumatized sphenoid sinuses, that's very, very common to see pneumatization of the sphenoid sinus. Sometimes people get concerned about that, but that is very common. They can fill up the entire sphenoid bone. That is nothing to worry about. That's what they should do. We can also see little stones up in the sinuses. These are little antroliths. So this is just a stagnant mucus that has started to mineralize, and no treatment is needed. But sometimes we can see root tips as well. So this is actually floating within the sinus, where you notice this is actually attached in here. You get these little projections. So this guy is actually floating within the sinus. So this is our little root tip. And you'll notice we have opacified sinuses. So you may need to refer that to ENT based on the symptoms of the patient. So if the patient has sinus symptoms for longer than 2 weeks duration, we'll want to go ahead and send them. We can see dental material in the sinuses. The beauty behind this is that the little cilia within your respiratory epithelium do exactly what they're supposed to do. And you can see that they're removing this little dental material out through the osteomeatal complex. Patient's probably going to swallow that shortly. So we really don't need to do anything about it. Really amazing the way the body works. Implants in the sinus. Yes, absolutely. In fact, this one has osseointegrated because they're going to osseointegrate about 90%, 95% of the time. And this just proves that point. So no treatment needed with that one. It's going to stay there. Foreign bodies, we can see nice little BB within the sinuses. So patient has a history of being shot with a BB gun. We can see little osteomas. So these are little hyperdensities of bone. They're basically just our cortical bone. These are really known as a hamartoma, but very common within the sinuses. And we don't need to do anything about them unless they're impinging on our anatomical structures. So we see them about 3% of the population, 80% in the frontal sinus and 15% in the ethmoid sinuses. All right, so here we see another little one. And then, of course, you can see what removal looks like once they go in and remove them, because sometimes they need to do that. Airway space. We do commonly see our deviated septums and nasal spurs. We might have a polypoid mass. You'd want to refer that to ENT. We can get rhinoliths. So this is an elderly patient that is in a home. And it looks like at some point she stuck something in her nose and it calcified. So this is a rhinolith. Now this can actually start to erode down through the palatal bone. So it can cause a lot of erosion issues. This does need to go to ENT to be removed or oral surgery to be removed. Whoever, again, is good in your area. Limited airway space. Again, we did a just complete an airway space lecture. So if you want to know more about that, I would definitely go to evaluating the airway space. One of the things that I do need to state, though, is that we really are just looking for anatomical impingements within the airway space as far as utilizing our CBCT. We can't diagnose obstructive sleep apnea with our CBCT, but it's very helpful for evaluating some of our impingements within the airway space. And again, we can only state what we see within our x-ray as far as radiology goes. So, you know, enlarged adenoids and palatine tonsils, these are the things that we're looking for, particularly in our younger population. Now, you can get a compensatory enlargement of the lingual tonsils when the palatine and adenoid tonsils are removed. So that is something to think about, is that you could get this compensatory enlargement of the lingual tonsils. And research lets us know if that's enlarged greater than 2.7 millimeters, there's a high likelihood that patient has obstructive sleep apnea. So just know that that kind of goes hand in hand. The lower down the impingement, the more devastating that can be for the patient. Now we can see various masses. This is a soft tissue mass in the posterior nasopharynx region. We've got this enlargement called an antrochoanal mass, and definitely can see that. We need to send this to ENT. This needs to be evaluated and removed and biopsied. This was one we just had. This was a young gal, 21-year-old female with no stated history at all. When we're looking through the scan, we could see, yeah, it looks like we've got some surgical screws. So we do have a history of trauma. And we see this well-defined air-filled hypodensity that just went right along that airway space. It's just lateral to the aryepiglottic fold within the region of the piriform sinus. And it's air density. It's got an air contrast level to it, but it has no connection whatsoever with the airway space. So this is our pharyngocele, laryngocele. It can be combined. This one looks to be combined. We don't see the termination or the apex of it. This needs to be sent on for additional imaging to be better looked at. But we can see these, if there's some sort of increase in pressure, along with a weakness within those muscular soft tissues. And so you might see pharyngoceles or laryngocele in a patient, for instance, that plays brass instruments. So a trumpet player, trombone player, that sort of thing. Occasionally, it can be caused by trauma. So that's why we kind of put the trauma in there. Again, this is definitely something you need to send on to ENT to be looked at. Now, occasionally, I do have to put my caveat in here. 5% of the time, the patient will have some symptoms. 95% of the time, they won't. Completely asymptomatic. 5% of the time, they're going to complain of difficulty swallowing, choking, when they're eating their food and that sort of thing. All right, real quickly, we're going to look at some skull base before we wrap it up today. Pineal gland and choroid plexus calcifications. We do typically see those within our CBCTs. They are going to be right along the midline. Pineal gland is right along the midline. And the choroid plexus calcifications are kind of bilateral to that. They make this beautiful little triangle back here. But we can definitely see those calcifications within that choroid plexus region. This is completely normal, complete variation of normal. Again, no treatments required. If you're ever concerned about it, please feel free to send that on to a radiologist. Enlarged sella turcica, yes, we can see those. If it is grossly enlarged, if it's larger than the size of a dime, which is about 18 millimeters, we want to send that patient on for additional imaging. This was a very, very large one. We're very concerned about what this might look like. And you'll notice you don't have any sphenoid sinus. Your sphenoid sinus is gone. So we're starting to worry about a pituitary adenoma or craniopharyngioma, and clearly we can't see that with the CBCT. So this patient has to go on to neurology and have additional imaging. If you want to send them through their primary care physician, you definitely could. Or if you can refer directly, you can always refer to neurology to go ahead and have some additional imaging and rule out pathology. But we get a couple of these every year. All right, this one, we have some calcifications within the skull base, and you can see it's within the brain tissue. And it is kind of attached to that sphenoid ridge and causing some erosion. And we know that our intracranial meningiomas can calcify. They are a benign tumor. They are one of the most common benign tumors we'll see in the brain. And so when we see this type of calcification pattern, we do, again, send in neurology. They need additional imaging to rule out an intracranial meningioma. But these patients, because they're benign, they may not know that they have this. They might not even have any neurosensory deficits. And you are going to be the first one to see it and send them on. And especially right now, with all the patients having gone through, our COVID pandemic, they're afraid to go see their physicians. They're afraid to go to the hospital. You might be the first one picking it up with your imaging. This was another one that we just got. This was a large skull base lesion. You'll notice that if you're comparing one side to another, we have some really gross asymmetry with expansion and thinning of the cortical borders. When we're looking at our axial sections here, you can see that we definitely have some expansile lesion within the sphenoid ridge. And so it's within our left greater wing of sphenoid with extension, actually extends down into the infratemporal fossa region. It extends posteriorly into the Meckel's cave region. This thing is ginormous. It's probably been there for about 20 years. Neurosurgery, we talked with neurosurgery about this one, and they said, yeah, it's probably been there a really long time. They were hoping that this might be an intracranial meningioma, but it could be another type of bone lesion because it does look like it's completely within the bone. So it could be something as a central giant cell granuloma or an aneurysmal bone cyst, but definitely needs referral to neurology, or they were actually wanting a direct refer to neurosurgery for additional imaging for this. And again, we're picking these things up with our CBCTs. We can see malignancies. This is a malignancy within the clivus. It had that patchy sclerosis and loss of cortical borders. And I know quickly because our time is running out, so I'm going to jump through real quickly through our orbits, although orbits are fun and we see fun things like our magnetic false eyelashes, which are pretty popular nowadays, but and a whole bunch of our soft tissue calcifications. But I really want to show you, because we've seen a bunch of this year, I want to show you some of our malignancies within the cervical spine. And so pop this one up. What you're looking for is this patchy bony sclerosis. And again, we've seen quite a number of these as complete incidental findings. Some of these patients knew they had something, such as multiple myeloma. One patient had a history of breast cancer. But you see this patchy bony sclerosis with loss of cortical borders. And that should be a red flag to us that we have these multiple lytic lesions with that patchy bony sclerosis. Unfortunately, we are seeing that quite a bit. Again, people did not go to their doctors over the last 2 years. And so I think us as dentists, we've always been part of the medical community, but we really definitely with this technology, much more involved, much more of a team player than we even were before. And our medical colleagues are really seeing that as well. So we've seen some real nice collaborations with that. Anyway, all right. Well, thank you guys so much. In summary, we see a lot of things with our CBCT. It is an amazing, amazing technology. Definitely we could do a part 2 of this because we see so much stuff. It'd be fun to share some more of our interesting and fun cases with you. And yeah, are there any questions? And again, when in doubt, you can always refer.
All right, let's see here. What are the most common challenges in communicating these findings with patients?
Well, I think that anytime a patient sees something on their scan, especially something like an anostosis, their mind always goes to cancer. And so patients can really be freaked out a little bit by that. And I think that it's up to us to really help educate them as far as the radiological appearance. We can say, Mrs. Jones, there's no expansion, there's no thinning. It's the same, we could say, I guess, the same color as our cortical bone. It lets us know it's just cortical bone in this area. It's really nothing to worry about. So I think that from that standpoint, it's really just calming down the patient. When we get, like the 21-year-old that came in and now we need to send her to ENT, that becomes a little bit more difficult because obviously mom and dad are going to be quite concerned about that. And so I think that knowing, the signs between benign versus malignant entities is very important. And we can say, what, it's just, an air fluid level, really nothing that we need to worry about, but we do need to look into it, make sure that there's not something else going on. Kind of reassure them that way. I know that myself, my daughter just hurt her knee. We had imaging and it looks like she has a little osteochondroma. And so the radiologist came down to talk to us, very concerned. Obviously, they're like, well, the first thing we want to let us know is we want to let you know there's nothing to be concerned about, but we did find something. So, it was kind of reassuring. Okay, yeah, it's nothing to be concerned about. Obviously, I know what an osteochondroma is, so I'm not going to totally freak out, but, our patients that don't know what something like that is, they might really worry about that. And of course, we can see osteochondromas within the temporomandibular joint region as well. So anytime I think that we have a pathology, knowing whether it's benign versus malignant, a very difficult conversation, of course, would be, for instance, the gentleman that thought that his lung cancer was in remission and didn't realize that he had metastatic lung cancer everywhere. And actually, that case, it was absolutely everywhere, but including within the temporomandibular joint region. And here he's gone from, oral facial pain expert to oral facial pain expert, thinking it's just TMJD that he's worried about, when really he had something more going on. And how he fell through the system, I'm not entirely sure. We're not always privy to those things, exactly what happened. That's why we always want to make sure we state the facts. But that's a difficult conversation to have with a patient, especially right at Christmas time, saying, hey, Mr. Jones, I think we might have some metastatic disease. You can always say, we're not sure, but we'd really like to send you on to your oncologist to get a PET CT and to get a better look at that, just knowing your history. And I think that patients can appreciate that. Obviously, for him to know the truth of what's going on is important. And I know those things can be extremely, extremely difficult. It was hard for us writing the report because we feel so bad for that patient. We feel bad for the clinician as well, having to let the patient know. But the beauty of it is that it was caught on imaging. He does know he has it, and now he can go to the right people to try to help him with what's going on. So yeah, it can be difficult to discuss this with patients.
Oh, right. Is there a software that permits the mapping of the canals of a tooth?
Yes, most CBCT software that came with your machine can map it. If it didn't, for whatever reason, there is software like CCAT Air is a independent software that can be used with any CBCT. There's also, I think, BioHorizons. So there's a number of different software out there, and there's free software out there as well that you can use that will map that canal for you. But I think it's BioHorizons. But there's a couple others as well. There's, of course, Simplant. You can buy Simplant. You could buy CCAT Air, that sort of thing. So there's a number of things that will do that for you.
Do you see a lot of bony sequestrum cases?
We do. We do have some good bony sequestrum cases, and I thought about putting one in, and I didn't have time. So I'll put one in for next time. But yes, we do see bony sequestrations. When we're looking at it as far as, calling osteomyelitis or bisphosphonate-related osteonecrosis of the jaws, or drug-induced osteonecrosis of the jaws, however you want to call that, we do look for those sequestrations, those little necrotic areas of bone and that sort of thing. And that helps us when we're trying to decide what it is that we're looking at. So yeah, we do typically see those.
If you take a CBCT scan, is the dentist responsible for all aspects of the image?
It's a great question. Ethically speaking, we are responsible for everything in our CBCT, just as we are responsible for everything in our pan and lateral self. And in our pan and lateral self, we technically see all of the anatomy that you see within a CBCT. It's just harder for us to differentiate it because we have all the 2D superimposition. So actually, we've always been responsible for all of it. We can just see it a whole lot better now. So ethically speaking, what do we need to do as dentists? We need to evaluate the volume. We do need to look at the entire volume and document that we have reviewed that. So if you want to put something in your chart, maybe you want to look at it, break it up by various areas. You could say, maxillary sinus is clear, TMJ is within normal limits, something like that to show you have reviewed the scan. One of the things that really helps us, especially if we don't remember all of our anatomy, is to look at symmetry. So does the right side look like the left side? If it does not, it could mean there's pathology. It could mean it's a variation of normal. So always then go put your crosshairs on it and look at it in all three planes. And if it looks atypical, you might want to send that on to a radiologist. Once you've sent that on to a radiologist, your liability is covered because the radiologist is going to know what they're looking at, hopefully, and give you a full report as far as everything that you're seeing and let you know whether it is normal or not. Legally speaking, I would say the majority of people that we see get themselves in trouble right now are getting in trouble because they didn't take the scan, not because they did take the scan. And certainly I would think if push came to shove, we are really going to be responsible for what's within our maxillofacial region. If it's outside of that, you'll probably find like neuroradiology that'll say that's outside of the scope of dentistry. But ethically speaking, for our patients, we want to be able to catch those things and treat them appropriately. And I think that that's what this technology is showing us, is that we see so many things that we catch very early on, and we can send that patient off where they need to go to appropriately. They may not have even known they had that particular lesion, and yet you see it and you're saving that patient. And I think that's what's really, really cool.
All right, and we'll end with this final question here. Is the standard of care for implants or extractions a 3D image?
It's a great question. Now, as far as radiology goes, we're not going to say standard of care because that's clearly what happens in your area. But what I can tell you is all of the position papers that have been out now for about a decade. So we're talking at least 10 years, these position papers have been out by the American Academy of Oral and Maxillofacial Radiology in conjunction with dental implantology states that CBCT imaging or three-dimensional imaging is the method of choice for evaluating our patients for implant treatment planning. So that came out 2012. It's been out a very long time. And I think that if anything goes wrong, in fact, we were told in 2015 at our academy meetings by the malpractice attorneys, if anything goes wrong during implant placement and a CBCT was not obtained beforehand, they say that the dentist is not defendable. That's coming from the malpractice insurances. So it's being pushed more from that legal side. I know that I've helped out with several implant cases. Occasionally we are sent cases by an attorney where they say, can you please evaluate the implant and where it's located in relationship to the mandibular canal? And if it's into the canal, it's pretty obvious as far as your CBCT. What I would say is everybody takes a CBCT after the fact, 100%. Everybody takes a CBCT when the patient walks in and they're numb. Just take it beforehand. It makes it so much easier. It makes your life so much easier. You don't have to, be as concerned about your anatomy because you can see your anatomy. So I would say from a radiological standpoint and from what we see on a daily basis, I would just take the CBCT beforehand. It's going to save you so much. I mean, if these things go to court, you're talking, they're going after people for like $1 million. How cheap is it to get the CBCT and take the image beforehand? And so that's kind of how I would pose that.
All right. Well, thank you so much, everyone, for the awesome questions. And thanks for staying late with us tonight. A lot of questions for Dr. Kohltfarber's previous webinars. So if you just email webinars@henryschein.com, I've got tons to send you. So do that and I'll get that over to you tomorrow. Additionally, if you have any other questions, webinars@henryschein.com. And Dr. Kohltfarber, thank you so much. I always enjoy learning some fun new words.
Thank you. Thank you guys so much for spending your evening with me. And hey, go UNC tonight. I'm super excited to go.
Oh, that's right. Go North Carolina.
We're hoping.
All right. Thanks, everyone.
All right. Have a great evening. Bye.